Recording. I keep waiting for the announcement. Welcome, everyone. It is the June 18th meeting of the Universal Healthcare Commission. I'm Mary Franzen. Next to me is Ross Valori, and I'm going to turn this over to our chair, Vicki Lowe, who can call the meeting to order.
Hello, good afternoon. Welcome to the commission members. It's now 2:03 and I call the June 18th meeting of the Universal Healthcare Commission to order. I'll begin with a land acknowledgement. I'd like to begin by acknowledging that as we gather today, we are all on the ancestral homelands of Indigenous people. We honor Indigenous people despite their removal from the lands where they lived, hunted, gathered, practiced ceremonies, and cared for their community members. We honor Indigenous people and tribes, whether officially recognized by the United States government or not, as they continue to care for these lands and their community members. As health professionals, it is important that we also acknowledge the impacts of the removal from traditional lands, of children stolen to boarding schools, and of the the oppression of culture and traditional ways of life on the health of Indigenous people throughout the country and in Washington State. As we work to improve health in Washington State, it is imperative that we address the inequities of the past by understanding their impacts on the present. I invite each of you to learn about and understand the true history of the Indigenous lands that you reside on. Is Ingrid here? Did she? I don't see her yet, right?
We haven't seen her yet.
Okay.
I don't think she's here yet.
Well, we're waiting for our newest member, and we'll more about that in a little while. But we'll have Ingrid Allray joining us. She is representing the Office of the Insurance Commissioner now after the retirement of Jane Beyer from State Service. So hopefully we'll get her here soon and we can be welcoming her. Mary, would you like to take roll call?
Sure. Thank you, Vicki. And I'll just share that my computer has just informed me it's about to restart. So I'll do my best to keep up on everything and peek over at Ross's computer. Really a bad moment. Okay, I'm going to call your name. And when I do, please unmute yourself and let us know that you're here. Chair Vicki Lowe.
Here.
Joan Altman.
Here. Hi, all.
Senator Annette Cleveland.
I'm present and attending virtually today.
Yeah. Nicole Gomez.
Here.
Dave Eisminger.
I'm here and I'm in person with everyone. Well, with HCA staff.
Tao Kwan Get.
Good afternoon. I'm here virtually.
Vidisha Mandal. Vidisha let us know ahead of time that she's traveling and unable to attend today. Representative Lisa Parsley.
Here and virtual.
Omar. I believe Omar reached out to say he can't make it today. Representative Joe Schmick.
I am here virtually.
Mohammed Shadane.
Thank you. I'm also here virtually.
And our newest member, Ingrid Allray. Has Ingrid joined us?
Not yet.
Okay. Well, we will keep everyone updated as folks join and we have enough people for a quorum. So, Vicki, I think it's back to you to approve the April minutes.
Thank you. So yes, our next bit of business is to vote on approval for the April meeting minutes. Is there any discussion or proposed changes to the minutes? Nikki.
I was going to move to approve.
All right. So we have a motion. Looking for a second.
Second.
I move to second.
All right. Second, third, and fourth. All right. All those in favor say aye.
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 Any opposed? All right. Motion approved. We can move on to public comments.
Vicky, I
Since our-
did want
Oh,
oh, sorry. I was going to mention Ingrid is joined if you wanted
Oh,
to.
good. I was just trying to text her while I was talking.
Okay, so I will
Okay.
officially call the roll, and then Vicky, if you want to add a comment, Ingrid Allray.
I have no,
Just say present.
Hi. Sorry, present.
Great. Welcome.
All right.
Yeah.
And as I said, Ingrid is here for the Office of the Insurance Commissioner, stepping into some very big shoes left by Jane Beyer. And we'll hear a little bit more about that in a few minutes. Thanks for being
Thank
here, Ingrid.
Thank you.
Okay, since our last meeting, we have received a number of public comments. Here's a list of the written ones that we received between April 17th and June 4th, and they are in the packet to be read. Comments included support of our mission and encouragement to keep working towards our goals. We received messages about pursuing universal primary care as an interim solution, both in favor and opposed, along with questions about the details of the proposal. We received a memo about various efforts already underway in Washington to improve primary care. We also received suggestions about how to apply the OIC proviso funds. Commission members received these written public comments as part of their full packet, meeting packet for review. Individuals may also provide public comment during the meeting, which is what we're about to do, and we will hear from them now. So Harrison, I think.
Harrison's going to
Close
run the
the-
timer
all
for
right.
us.
All right, Harrison's got the timer. And for those online, please use your Teams feature to raise your hand. We're going to call on those who registered ahead of time, and then anybody else with a raised hand. And then, so when you're called on, if you can please say your name, and if you have an affiliation, could you please let us know what that is before you start speaking? We'll display the timer as a reminder of the 90-second time limit. When the timer stops, please wrap up your comments. So Mary, will you please start with the individuals who have signed up in advance of the meeting?
Sure. Thanks, Vicky. As usual, we're going to start with the folks who contacted us ahead of time, and then anyone in the room or online can put up their hand. We will be making it so you can unmute yourself. And again, look at the ribbon along the top. To the right, there's a little picture of a microphone with a slash through it. If you click on it, that will unmute you. So we will start with Chris Curry.
Hi, Chris Curry, Healthcare for All Washington. Healthcare for All Washington believes that if universal healthcare is to be implemented incrementally, it should start by replacing the Medicaid MCOs with an administrative service organization in order to free up funding, not by carving out primary care services for special treatment. Then, building on what Washington has already accomplished in the area of primary care, consider an integrated, collaborative, statewide system where primary care practices assume the responsibility for care coordination in exchange for an additional payment, as Connecticut and other states have done. How primary care is expanded is currently the statutory responsibility of the cost board and the HCA. It need not concern the commission at this point. Once this single payer system is established and tried for Medicaid, it can be gradually extended to the rest of the population. But first, the legislature needs all of the commission's recommended design elements. Please buckle down and get the design done. Stop getting sidetracked and making this harder than it needs to be. Thank you.
Thank you, Chris. The next person we have is Sherry McAvoy.
Hello, I'm Sherry McAvoy, and my written comment was the same as Chris from Healthcare for All Washington, and I'm the co-chair with Jane Grafton on Healthcare as a Human Right, the HUCS committee. And we're just basically reiterating what Healthcare for All believes, and HUCS confirms what Chris just said.
Thank you. We also have signed up ahead of time, Catherine Lewandowski.
Yeah, thank you, members of the Universal Healthcare Commission, Chair Lowe, and to staff for allowing us to give public comments today. My name's Catherine Lewandowski, and I'm a semi-retired registered nurse and the board vice chair of Whole Washington. I want to remind you about the article published by the WHO discussing the benefits to low and middle income countries in making investments in universal primary care in order to help them provide affordable care to their citizens that I sent to the FTAC meeting, I think back in April. I hope that we've not fallen to the level of low and middle income countries economically, but these are very interesting times that we now find ourselves in. That said, for us here in Washington and the United States, we all know and understand the savings and improved outcomes that we can achieve with investments in our primary care clinicians, both in training and increasing reimbursements to PCPs and primary care clinics. This is not something that we really need to study. What we do need is an analysis of how we can best finance a comprehensive and efficient healthcare system here in Washington State. I would like to encourage you to either try and collaborate on the great work with the University of Colorado that they're doing right now, or enlist the assistance of our own universities individually to evaluate the funding mechanism currently in the Washington Health Trust, to include examining other options available for securing stable funding for our universal healthcare system. And thank you again for the time and efforts that this commission is putting into this very necessary thing. You know, this is just so necessary, and for allowing me to speak today. Thank you.
Thank you, Catherine. One more person did sign up ahead of time, and that's Jane Grafton.
Hello, members of the commission. Jane Grafton with Whole Washington, co-chair with Sherry McAvoy of the HUCS committee. And I want to direct your attention to written comment that was submitted by Matt Wright, especially the last bullet point. It would be cost effective for the state of Washington to leverage existing efforts. And I encourage the commission to consider funding and using the microsimulation models that are being developed by the Colorado School of Public Health, as Catherine just mentioned. This could be a really beneficial way for us to get a leg up on the financing. Those models are going to be made public for other states to use in December of 2026. So please see Matt's written comment for more details on that. Thank you.
Thank you. And I just got a message that I sounded funny on the other microphone. I'm wondering if this one's working a little better.
Still
I
a little
sound
underwater,
funny.
Mary. Sound very robot-y, yeah.
Okay, I'm going to go sit next to Dave because I think that one worked better before.
Just to confirm, do I sound like a robot or no?
You do not sound like a underwater robot.
Okay. We will have Mary come over to me.
Were there any other public comments?
Yes, I say, here I am above water now, trying again. And I'm not looking at a computer. So if anyone can tell me if there are hands raised, we can open it up to public comment to folks who are attending today.
Just to say the sound's a little bit off again.
Mhm.
No hands?
I'm not seeing any. I'm not seeing any hands, Mary.
Okay, well, thank you everyone for your comments. And I think that closes out our public comment.
All right, thank you. As a reminder, the commission welcomes and encourages public comment and appreciates feedback. Public comment is an essential part of the process, and it provides an opportunity for public to have a voice, their voices heard at regular meetings. Public comment can be provided orally during the meeting or written form at any time to the commission's inbox. And I think somebody will put that in the chat for us. Our oral public comments are not accepted outside the public comment period. Commission members review and consider all public comments received, but generally will not respond to public comments during the meeting. If the commission deems it appropriate, a response will be provided in writing or at the next public meeting. Okay, so next we're going to hear report outs from the commission members. I welcome members to share any updates that align with the commission's work, and we'll start with the insurance commissioner, Patty Cooter, who is joining us today. Is she here?
Yes, good afternoon. I was having a little challenges with the technology, so apologies for that. I just wanted to start by thanking you for the opportunity to give a brief update of our work at the OIC. But first, I'd like to share, as many of you already know, that Jane Beyer has officially retired. We are very happy for her after her decades of work and dedication to improving the healthcare system for Washingtonians, but she is definitely missed. But I'm also happy to announce my new Senior Health Policy Advisor and Delegate, Ingrid Ulrey. And many of you already know Ingrid, too, from her extensive healthcare leadership and recent tenure at the Washington Health Benefit Exchange. I'm very excited that she has joined our team, and I know she's going to be invaluable to our efforts here. So I'd like to circle back to our presentation at the last meeting regarding developing a primary care model and why I believe it's so critical that we move this concept forward. We've received the filings for our individual health insurance market last month, and once again, as you probably all know, the insurers are requesting double-digit rate increases, and that's on top of the double-digit rate increases they requested last year. Now, we will give these filings a thorough review, as we always do, but we know that any increase is going to be very difficult for people to absorb. And at the same time, I continue to hear from people with insurance who cannot find a primary care provider or are waiting months for an appointment. And I know this is not what the consumers or providers want. We want people to be encouraged and supported to use primary care and to seek that care before a crisis hits. And that's why I've directed my staff to assess how to move this concept forward. I ran for this office because I believe that healthcare is a human right, and getting us to universal coverage is still my ultimate goal. But the crisis before us is growing, and states have always been the incubator of change, and I believe it's even more crucial that we act now. I believe this concept is an important building block that moves us closer to that shared goal, and I hope that you will consider this a core part of your universal coverage work plan. I want to thank you again for the good work that you've done so far, and I'm really looking forward to hearing about your ongoing progress, and just thank you again.
Thank you, Commissioner Cooter. Ingrid, anything to add?
I'll chime in later when we get to that part of the agenda, but just really appreciate the commissioner's leadership and vision on this. And, Jane leaving is big shoes to fill, and I will do my best. And I'm really excited. I've been following this commission on the sides for a long time while I was at the exchange and heard the reports from you, Joan. And I'm very pleased to be a direct part of it now as the delegate for the Commissioner Cooter. Thank you.
Thank you. Okay, we'll move on to our other representatives. Joan, do you want to go next for the exchange?
Ooh, I'm happy to. Hi everyone. There's a lot. So I'm trying to think of the best way to summarize. You heard from the commissioner about the rate increases in the individual market proposed for 2027. So we're in the midst of looking at what that means for plan options available to exchange customers and what it looks like with regard to affordability of those plans, with the shrinking federal tax credit and our Cascade Care Savings subsidy only funded for the next 1 year. We're really looking to see where we can, if there are any other state policy levers we can use to sort of mitigate some of those harms. We did put out a press release last month, which I can share and chatter with staff, looking at how many people have dropped given this sort of intersection of federal policies that are harming access. But we are seeing lower enrollment amounts and higher dropping amounts than we've seen in the past, and probably one of the largest decreases in my tenure at the exchange. So There is some good news in terms of state level mitigation that's happening, and there's a lot of activity going on around implementation of HR1 and some of the continued federal changes that are coming up. There have been some recent regulations released that are also impacting how we do business over at the exchange. So lots going on. I will say some areas of concerted effort right now. We have some lawfully present customers who are losing Medicaid and losing federal tax subsidies. So communication to them is starting to go out this fall, summer and fall, around how their coverage will be impacted. So doing some work there. Also looking, we had talked about facilitated enrollment and sort of enrollment, helping with these enrollment transitions of people coming off of Medicaid and needing to come and navigate the individual market. The legislature gave us some funding to do that. So we're looking at what that could be. And we also stood up our state health program for the undocumented, Washington Health Path. So even if the feds take action on our 1332, we've been sort of waiting to see when the withdrawal or sort of further attention on our waiver comes, contemplating further action there to kind of mitigate those risks. But in the meantime, we've set up a state program that lets people who are undocumented have a continued pathway to coverage as well. So taking steps that are positive at the state level to try to preserve coverage for people, monitoring impacts of drops and other pieces, and then looking ahead to 2027 levers that we could use to try to maximize coverage. It's a weird time to be Director of Coverage Expansion and Strategies at the exchange, but we'll get there. Happy to answer questions folks might have.
Thank you, Joan. Any questions for Joan? Right, Dave, do you want to give us an update for the Healthcare Authority?
Nothing's happening at the Healthcare Authority. Never a busy moment. It's very boring here. A couple of different areas. I try to highlight a few things from each kind of the bigger business lines for HCA. I'll start with the area that's closest to me, which is PEB and SEB. Just highlighting, we are a substantial part of the commercial market in the state, somewhere in the range of 19 to 20% of the commercial market. Our rate setting process and premium process is a bit different. That makes it harder to do an apples to apples comparison with the individual market, for sure, because of the collective bargaining agreement and the state's employer subsidy essentially for the bids of the various carriers, and the fact that we have a self-insured governmental plan that has a bit of a different flavor than many of the other parts of the individual market. That said, our premium process results in the revealing publicly at our board meetings next week of our proposed 2027 employee premium. So I will just say stay tuned a little while longer. Can't quite jump in front of that process. We do publish our board materials the Monday before board meetings. Next Wednesday is SEB. On Thursday is PEB. Both of them will have their materials up on HCA's website on Monday, and then our respective board meetings, and anticipating the board taking action on premiums for 2027 at their July 9th meeting. I think the part to remember is that there is, when you look at the rate of change in employee premiums in PEB and SEB, you do have to remember that we are highlighting the end of the math equation after the state's subsidy through the CBA has been applied. And so you can't do a direct comparison on the percent increases. But we do have some information in our materials that talks about the 5-year trend, year-over-year trend of the last 5 years. And I think there is some important information to share with everyone about the implementation of Senate Bill 5083, which is the Public Employee Affordability and Access Bill, which some people also refer to as the Reference-Based Pricing Bill. Those policies go into effect for January of 2027, and so we are seeing the effects of that in our rate development for this year. And preview of coming attractions, just as a slight spoiler, we're seeing essentially like our trends in the portfolio cut in half as a result of those implementations. So there is quite the contrast and some significant good news, if you will, on that perspective of that policy change as it is rippling through the PEB and SEB programs. So there's a lot of work right at this time of year because of the 2027 process. Then on the public option line of work at HCA, we are smack in the middle / near the end of the renewal process. There are May and June are important timelines for the carriers to submit their public option plans, and the simultaneous review by HCA as the contracting entity and purchaser of the annual plans for public option, and OIC in their review of rates and network adequacy and all of their regulatory oversight of the plans. Those are all occurring simultaneously, and we are nearing kind of the end of those reviews and decision makings from each of the respective entities about what service areas look like as we all move forward in the approval process for there. So there's been a lot of work in June on that front, and we're rounding the finish line on some of the decision making that needs to be happening for the renewal process for 2027 plans. So there should be more out in the public sphere on that relatively soon. And then on the Medicaid line, HR1 and its implementation, I think many people know, but please don't ask me to recite what exactly are the implementation timelines in the next 6 to 12 months, but there are many different parts that come online that the Healthcare Authority and other parts of state government are gearing up for. We are, kind of in the throes of some hiring processes for some of the work that needs to be done on a more frequent basis for eligibility determinations by the Apple Health Administration. And so we have recently hired, I believe, somewhere in the range of 15 staff as the first cohort of additional customer service folks to help with those eligibility determinations. And we will be continuing to do that cohort hiring over the next couple of months as we bring online the more frequent eligibility determinations that kick into gear over the next 6 to 12 months. Many different things to highlight, but that's what I chose to say today. Any questions? Happy to try to answer them. But we are all just kind of moving forward in this non-busy world. Sarcasm noted, for the record.
I guess just one quick follow-up, Dave. So for folks that are waiting for the PEB/SEB rates, those will come out next week. Is there an opportunity for public comment or any feedback that folks can provide for those?
Mm-hmm. So we will, like I said, we have our materials that are posted next Monday. The board meetings are open public meetings that have a public comment period. We have them at the end of the meetings for the PEB and SEB board schedules. So there's always the opportunity for people to speak during that general public comment on Wednesday and Thursday. We purposefully introduce resolutions for board action at one meeting and then ask the board to take action at the next meeting. There's some very rare emergent circumstances where we ask the board to take action at the same meeting it's introduced, but we're not in that situation. So there'll be time for people to think about and digest over roughly a 2-week period. They can submit written comment. They can also then attend those July 9th board meetings. And we always ask for public comment on each specific resolution. We tee up things for the board to act on a carrier by carrier line and rather than an individual plan basis. So they vote on a single carrier suite of offerings and authorize or not authorize plans as a set for each carrier, and we ask for public comment before each vote, as well as general public comment at the end of the July 9th meeting. So multiple ways in writing or multiple opportunities on the 24th and 25th or the 9th for verbal public comment.
That's fantastic. Thank you. And impressive recall, too, on your part with those dates. So thank you, Dave.
Any other questions? Okay. We'll go to Department of Health. Dr. Quanget, do you have an update for us?
Thank you, Chair Lowe. Just a few updates. Ebola virus is in the news. There's the third largest Ebola outbreak currently going on in the Democratic Republic of Congo and Uganda and South Sudan. There are no cases in the United States or in Washington. And the main responsibility of our public health system currently is to monitor travelers returning from that part of the world who may have been exposed, monitoring them for any symptoms and ensuring that that they know what to do if they develop any, so that they can get appropriate care and appropriate testing if necessary. And I mentioned this because the response to this kind of disease, an outbreak, a global outbreak, is stronger if we have Washingtonians with good healthcare access. We continue to keep an eye on measles. We've been holding steady at 45 cases for 2026 over the last couple weeks. We continue to be concerned about the possibility of undetected transmission in the community, particularly with large influxes of visitors, such as through the FIFA World Cup and also with summer travel. And so we are working with partners to increase adult vaccination against measles, to try to increase the number of adults who are up to date on their MMR vaccine, because that's our best protection and our best chance at preventing a large outbreak of measles that several other states have had in the last year or so. And this highlights the importance of the last update I'll have, which is on our immunization roadmap. So this is a priority of our new Secretary Dennis Worsham, and it is a 4-year strategy to increase access to immunizations and strengthen immunizations for all ages in our state. And over the last few months, the team has been working with internal and external stakeholders to develop a draft, and that draft will now be shared and hopefully finalized this summer. And from there on, we'll talk about implementation to strengthen access to vaccines for all Washingtonians. And that's all I have. Thank you.
Thank you, Dr. Quangat. I know I've been in some meetings with you and we've been talking about some cuts to the foundational public health services. And I think was there a few of them that might impact healthcare, like the HIV, hepatitis. I'm trying to remember, because I know we were concerned that it would have impacts beyond just public health, because if the same cuts are being made in other programs like Medicaid.
Yeah, thank you, Vicki. I will have to look back to see what of our programs that do provide direct services are impacted by the decrease in FPHS funding, because you're right, even though we are a public health agency, there are several programs that do provide coordination of care or increased access to treatment or medications, and if certainly there would be negative impacts if those programs don't have the resources they need to continue. Thanks.
Thank you. Any questions for Dr. Quangat? All right. Any other commission members want to give an update? Senator Cleveland?
Thank you, Madam Chair. It's good to see everybody. As a member of this commission, as well as the current chair of the Senate Health and Long-Term Care Committee, just want to share that I continue to strongly support the goals of the Universal Healthcare Commission. I'm really grateful for everyone's engagement and commitment to those goals. I want to share today that while the legislature is not currently in session, of course, our legislative work does continue in the interim. And so want to make people aware of the next upcoming Senate Health and Long-Term Care Committee that is scheduled for June 30th from 1 to 3 p.m. And you can access an agenda for that meeting at www.leg, that's leg.wa.gov. You can also watch that meeting virtually via that website, or you could also attend that meeting in person. And we are continuing to be very, very focused on our shared goals and priorities, access to healthcare coverage, access to healthcare services, and affordability. But we'll also, in this next upcoming meeting, be very focused on what we've heard reported out by some of our other members today, the work of our agencies in our state in terms of implementation of HR1, what those impacts are, and what our next steps are in front of us as a state. So appreciate the time today. Thank you.
Thank you. Any questions? Any other updates? All right, thanks everyone for those great updates. I don't know if I want to say great, but thank you for your updates. So next, if you can turn to tab 4 in your meeting materials, Mary Franzen will provide a work plan update and a report, and we'll get a report out from the May FTAC meeting.
Thanks, Vicki. I hope this microphone's working okay. If not, we can always go back to yelling at the ceiling, which is sometimes what we do in this room. I'm doing double duty today. The work plan update. Also, Pam McEwen was not able to join us, so I am delivering the report out from the FTAC meeting. So start with the work plan update. This is always our good reminder of what's in the RCW, the enabling legislation for the commission. Immediate and impactful changes in healthcare access and delivery system. That's what we usually refer to as transitional or sometimes interim solutions, and also the universal system design. Can you go to the next slide? Making you do it. Here's our work plan status. The column on the left, which is labeled universal system design, those are the key components of the design. I think Chris alluded to them in his public comment earlier today. Those are the components that we are marching through. The green means that the initial proposals have been adopted. The orange means it's in progress. And then the gray are the ones that are coming up next. There's a little omission in the legislative reports column because we are right now hard at work on the 2026 ledge report. Forgot to put that in there, but the staff is working hard on that. We expect to have the first draft. Well, the commission will see the draft for the first time at the September 3rd meeting. And then I can't remember the date of the October meeting, but that's when we will be looking for final approval. That's a mid-October meeting, aiming for a November 1 submission to the legislature. So on today's agenda, there's going to be a report out from Universal Primary Care Work Group. And also Harrison, the last item on today's agenda, will be talking about provider reimbursement, the draft proposal, and a roadmap. All right, now moving to FTAC. Overview from, this is the main topics we'll talk about from the main meeting, the public comment, and then they talked about provider reimbursement and proviso. Is it this one? Yes. There we go. Quite a few public comments. Vicki alluded to this earlier on the last set of public comments that we had at the commission. There were comments about including dental and vision coverage in the universal package, support for the Washington Health Trust bill, some feedback about the provider reimbursement proposal, again with the suggestion that only administrative service organizations, not managed care organizations or their carriers, be invited to participate in competitive contracting, and support for including primary care as part of a universal system rather than as a transitional solution. There's quite a bit of discussion about the provider reimbursement proposal. This is something that FTAC and an FTAC work group have been very hard at work on. There's a timestamp to the recording. I'm not going to go into great detail on this one because a lot of their work and a lot of the edits will be discussed in Harrison's presentation later today. So you'll get those details later. Kind of the same story for OIC proviso funding. There's quite a bit of discussion, and that also will be discussed in greater detail in a presentation later during this meeting. There's a timestamp to that conversation as well. These are all taking you to the recording of the FTAC meeting. Following that meeting, the staff circulated proviso funding ideas to FTAC members. We incorporated their feedback. You'll be seeing that on a later slide. And also I can see in the attendee list, we have some FTAC people here with us today, so thank you very much for joining. And then some of the longer emails, all of the input from FTAC is incorporated into the slides. Some of the longer emails are also attached as an appendix to this packet. As I said, we're going to be getting to that later today. I don't know if there's questions about either the work plan or FTAC. Yeah, I'm assuming the sound is okay, and I don't see any questions, and I'm still watching my computer count down. That's back to you, Vicki.
All right. Thank you, Mary. No questions? Okay.
Can I
Oh,
can I ask?
okay, Mohammed.
Yes, thank you. I was trying to figure out how to raise my hand in this thing, but it didn't work. Just a quick question. I missed our last commission meeting. So I'm just want to get up to date with. So have we voted for the universal primary care route? And decided that we'll go that way, or is that question still waiting from the commissioners' response?
Yeah.
Perfect segue to the next topic. So
Yeah, short answer is that no vote has been taken. That is about what we're about to talk about, a report out from the work group. What we envision, and well, this will be in the slides we're about to get to, possibly a vote at the September 3rd meeting. So more discussion, presentation of workout today, vote at the September 3rd meeting. But of course, when votes happen is up to the commission.
Got it. Thank you very much.
Yeah, so at the last meeting, no vote on universal primary care, but there was a lot of discussion about what we needing to better understand it. So we have a report out next from the Universal Primary Care Work Group. And we'd like to thank the work group members. That was Nicole Gomez, one of our commissioners, Hiroshi Nakano, who is a member of the Financial Technical Advisory Committee, Representative Partially, another commissioner, and Ingrid Allray, who was beginning in her position as a commissioner. So the work group met at the request of the commission and helped frame the decision about pursuing universal primary care as an interim solution. So Mary will start us off, and then we'll hear from Jen Scott, and Hiroshi Nakano will also to describe the outcome of the meeting.
Thanks, Vicki.
Right, Mary?
Sure. So again, a quick overview of what we're going to talk about. The background from this idea, the decision and the proposed timeline, which is what we were just talking about. The report out a summary of the work group discussion and the conceptual framework that they talked about. I think that's where Hiroshi's going to jump in and help us out on that one, and then talk about some key questions and discussion. And there's a next step slide that's completely blank, because I think we're going to figure out what our next steps are as we're talking this through today. So to the background, I think most people are familiar with this, a proposal to develop a universal primary care model. To be a carve out of private insurance, could be phased in by market. There's much more detail about this proposal in Appendix A. I think it's A of your packet. It is some materials developed by the Office of the Insurance Commissioner that gives more detail about it. But I think, one thing that we want to stress is that we're not talking about an either or approach. We're not talking about, either universal primary care or an eventual universal system. It would be a step toward the full system and a transitional solution that in the interim could improve and expand access. This, again, we were thinking that perhaps September 3rd is the appropriate time for the commission to take a vote. The question is, should the commission integrate universal primary care into its work plan as a foundational step toward a full universal system? So that is the background and the discussion. And I am going to ask Hiroshi, one of FTAC member and work group member, to start talking about the work group discussion and the conceptual framework that was discussed.
Great. Thank you, Mary. Can people hear me? Great. Okay, thanks. So we're going to keep my presentation relatively short. There was a lot of discussion about a lot of things, including a lot of the detail that's in your appendix. So I would invite you to take a look at that information to do when you do a little deeper dive. So as a work group, we generally came to the conclusion that we were supportive of the work moving of the existing work plan for this commission. And we would like to see the addition of the topic on universal healthcare to be added to that work plan. We don't have a fully scoped proposal as of yet, but an additional model that could be designed alongside with other parts of the universal system. And again, your appendix outlines a couple of different potential models that have been actually evaluated in depth in some areas in the state of Washington. And then universal primary care is another possible avenue for improving primary care in Washington. We've heard from public comment and folks on the commission that access to primary care is difficult right now. And it's not getting better. And so this proposal, when we talked about it, could be one way to improve access while we're still trying to put together a universal system. And then we believe the work group believe that whatever proposal we come up with is that it should be evaluated based in how it fits into the conceptual framework of this commission. So again, when Mary, in the introduction, when we talked about that this is not an either or concept, the idea is that it needs to fit with wherever we end up in a universal system. And then next slide, please. And then we talked about a conceptual framework. We looked at a couple of different options, we talked about a couple of different options about how to move forward with this, with the overall landscape of universal healthcare coverage. And so we talked about it could be a phased implementation. And conceptually, what we're thinking about there is, do you take parts of the system and then implement them in a stepwise fashion? Or do we look at it as a transitional solution, that it becomes kind of a bridge between where we are today and where we want to be in terms of a total universal system? Or do we think about this more as a foundational step, that a lot of the things that we need to figure out in order to do universal primary care is fundamental to putting together a total universal system. So things like, how do you attribute members to providers? How do you govern the overall system? Even how do you finance the system is part and parcel of this. And again, there's an outline and a comparison of that in the appendix. So that's generally our discussion with the work group, and really appreciate those that participated and the interest that the commission has on this topic. So I'll stop there. I think it's back to you, Mary, or any questions that you may have with the work group.
I'll pause first to see if there's questions for folks. I don't see hands. Jen, I don't know if you want to jump in on this one as well. These are some questions we came up with, thinking about the framework we were just discussing. Does the universal primary care fit into that framework? Where, and if the answer is yes, where? And when do the decisions need to be made about, is it a transitional step? Is it a foundational step? Does it fit into the framework? I mean, at what point does the commission need to start making those decisions? I don't know if anyone wants to jump in. I mean, the other questions here, does it fit in with the commission's charge as defined in the RCW? And again, what additional information do you need to make this decision. You know, the decision we discussed at the very beginning of this. What else do you need or want to know to be able to move forward?
I think that I would just add that the part of the idea about what information do you need to move forward. I know in the previous discussions there has been, it's kind of been, all over the map and gotten into some questions that were detailed and maybe more in the phase of implementation. And so I think the question is really, what is the level of information at this point in time that would be needed to move forward, understanding that, that the model's not fleshed out, and it seems like the proposal would be that it would be added to the design of the universal system as, either transitional or, however it fits into the framework.
And maybe while folks are thinking about any questions they have, we could turn to Ingrid, who is with the Office of the Insurance Commissioner, and they provided the very nice documents in the appendix that are kind of contextualizing the proposal. Is there anything you'd like to add, Ingrid?
Oh, thank you. Well, I just really appreciate this discussion. Thanks for your report, Hiroshi. I know when I was speaking with Commissioner Cooter about this, she was reminding me that she was a strong proponent of the legislation that created this commission, and of the direction that included what you saw in an earlier slide was that the commission worked towards creating immediate and impactful changes in the healthcare system. And you heard her strong commitment to the ultimate goal of a universal system for all. I think as someone for myself who started in my 20s as a community organizer working for a single payer healthcare ballot initiative in California, which didn't pass. I know that this is a long haul effort, and I'm so grateful that the state of Washington has this structure of this commission to create that roadmap to a really huge and expansive change in how healthcare is organized in our state. And for as has been mentioned, in terms of what's a foundational step or how can we move towards that in a practical way. Mary, I'm wondering if you could, I think visually this is helpful, if you could show slide, I think it's 65 in the deck, which is a simple table that, this is a Jane Beyer table, I will note. Jane was really good at making tables. And think about the major pieces that this commission is working on to create answer all the detailed questions about what would a full universal healthcare system look like and how would the key elements be organized. One way to think about this as a foundational step is that to create a universal primary care system, it's the same questions and design issues that need to be deeply fleshed out, and that we need resource and capacity to really do that work. And I think that's what the commissioner is really interested in, is as you see, she's already dedicated funds from the OIC regulatory account to this commission and is interested in doing more to expedite the work we're doing together. This chart is just an illustration of the key elements in the work plan and that this commission has been thinking about in terms of what would the governance model look like? What's eligibility? How do we enroll consumers? How do providers participate? How are they paid? What is the basic benefit package? Is it just primary care or advanced primary care? And if so advanced, how do we define that? And then quality measures and thinking about, wow, a future world where they were more consistent across, instead of every different payers having different quality measures, just one set of sensible quality measures. Reimbursement, and then phased implementation. What's our go first, funding and financing? So the concept here in terms of thinking of this is something immediate and actionable that we could work towards together, is the design of all these elements to expedite that and have proof of concept or use cases on, for example, if we're carving primary care out of private insurance, perhaps establishing a trust as envisioned for the broader universal healthcare system, and then modeling how that works and how it would be governed. So in the view of the commissioner, and in the discussion we had in the work group, the thinking here is that taking a piece of it that we could create, and the creation of that sets the stage for the creation of the broader model, gives us a way to jumpstart and expedite this work and move faster towards immediate and impactful changes that will help real people in our state. And I think it's important to note that this is going to be a really tough session. I mean, as you heard the agency reports, we have the prospect of the uninsurance rate more than doubling in the coming years. We haven't tackled how to contain healthcare costs. These issues are going to take up a lot of space in the immediate upcoming session. And we also want to make sure, as we're tackling the very difficult present, we're preparing for the future. And so one way to prepare for the future and give it more capacity and focus is to have a dedicated space to create a foothold for a discussion on key questions, like first and foremost, how are we going to ensure there's enough primary care providers in the future and address the workforce pipeline issue? And then how would we work all these design elements and then report back to the legislature on with a fuller picture of what this model would actually look like and what some go first populations would be to fold into it. So that's some of the thinking. And you heard the content from Jane Beyer at the last meeting, and really the deck that we provided for you in the appendix captures a lot of what you already heard from Jane, as well as the conversation in the work group. So happy to take any questions. Oh, I'm sorry, I did want to note too, I just want to thank Healthcare for All Washington. In the packet is their letter, and it is a really good articulation of the many questions that need to be answered, and the need for us, the need to create space to ensure that we have the resources and the capacity to do so.
Thank you, Ingrid. And as a reminder to commission members and the public, in the appendix is the slides that Ingrid was referring to. And I apologize, I'm going to go back, so maybe cover your eyes while I jump through the slides again. And I believe, Vicki, we were, or Mary, taking questions.
Let's see if anyone has questions or questions about the proposal, or we also had, is there additional information you would like between now and September? Representative Schmick.
Thank you. I did have a question, and on page 59 of the appendix, it says in there that the prior authorization will be reduced. Could someone explain to me what the mechanism or how that process would work, that we would see a reduction of prior authorization?
I'm happy to take that, but Hiroshi, defer to you. Would you like to tackle that one?
Yeah. I
Thank
think
you.
what we're thinking about is that as part of the model, then we could, especially at the primary care level, mental health, if the model included integrated behavioral health also, that we would design the system in a way that it would reduce the need for prior authorization as that patient was in the primary care system. And so you could think about what are the types of things that impact prior auth at the primary care level. There's obviously different types of drugs that could be dealt with, and additional services that we would want to see an expanded primary care provider do, that hopefully we could eliminate prior authorization for.
Mary, I see Dr. Quanget's hand up. Yeah.
Yep. Dr. Quanget.
Thank you. And I just have a couple of comments. One comment is that I do think that universal primary care fits the charge of this commission, not only because it's an impactful change, as Ingrid mentioned, but also because one of the charges of the commission is to address healthcare costs, and studies have shown that primary care can be cost saving. The other comment I'll make is that having been a primary care pediatrician for much of my career, I'm aware of a lot of the challenges that my colleagues face, and as well as colleagues in primary care internal medicine and primary care family medicine. And I hope that the model of universal primary care can also address the need to strengthen that connection between primary care providers and patients, and as the slide says, lessen the paperwork, lessen the administrative overhead that I think contributes to a lot of burnout amongst primary care providers, and also makes it more difficult to recruit new physicians into primary care. So in addition to quality of care, I hope that if we do decide to go forward with the universal primary care, that we also think about the workforce piece, how to maintain and strengthen the workforce of primary care providers in our state. Thanks.
Thank you. And I can no longer see hands, so I'm going to ask Jen and Harrison to keep an eye on things, but I think Rep. Schmick's hand is up.
Yep, I have another question. Thank you. What are the measures are we going to put in place to evaluate whether this is going to work or not? Is it just going to be 12%? That's the goal of overall spend on primary care. How are we going to evaluate this and put measures in place? And then the other end of it, if it's not working, then what?
So, Representative Schmick, this is Hiroshi again. We hadn't gone into that level of discussion in the work group. I think we met once or twice. I can say, though, that all the proposals that we're looking at in terms of primary care all outline quality measures as one measure of success. We would want to see that quality improve over time with this. And then any other thought that I have is more my thoughts rather than just than the work group. But we've heard about primary care as being a cost containment strategy that we would hope to see, I guess, the twin goals of access and affordability come up from something about putting more resources and expanding the primary care base.
Does that answer your question, Representative Schmick, or is there additional detail we could provide for you?
I think that it was commented, and I think it's probably true. It's early in the process, but I also think that there needs to be very clear measures. If you're going to do this, how will we know it's working? It's not working. There was another comment in the appendix. If I can ask another question, in the appendix, and it said wanting Medicare and Medicaid, needed waivers to do that. With the current administration right now, the real emphasis is on lessening the federal dollar investment into different states. That seems to be their overall goal. If we are not able to do that and then we fall short in running this program, does that fall back again to the taxpayers as we fund this. And I realize this might be a bit early in the process, that you're in discussions about this, but I think it's very real. At the end of the day, are we just going to spend a whole lot more money establishing this, doing this, with no way to get out of it? And again, without the measurable goals, it's hard to determine whether we're getting a bang for our buck. Thank you.
Thank you. And I'm not sure if any work group members would like to reply to that, or if not, happy to move on to Mohammed. And thank you,
Ross,
Rep. Schmidt.
if I could just say, if I could just comment briefly, and Representative Schmidt, thank you for these questions. One is, these are the things that would need to be scoped out, but certainly for any implementation of a universal primary care model, the go first populations would need to be populations that are more under our authority, our state authority, given the difficulty and challenge of federal waivers. And then the ability to judge success, or what are the goals, is looking at those spending patterns. And there's quite a bit of data out there on the pattern of investing in primary care reduces hospital spend and more expensive invasive care later on through prevention and the basic, Dr. Clongette, the basic public health principles. So looking at models, we know there are some models already occurring in the private sector. Boeing, for example, has this type of model that they've implemented for their employees and are seeing some very interesting results in that effect. And then another indicator is how many people the workforce issues of primary care providers. Are they staying in the profession? Are we better able to attract more if they think about a future for themselves of serving patients and not having patients having many different carriers and many different plans, and for them having to spend a lot of time on the side of insurance building and prior authorization, and instead being able to have that relationship with their patients, which we hear over and over is a major goal of what primary care providers seek to do, is to know and understand their patients and their needs and serve them in a more comprehensive way, and be able to more successfully get them connected to things like behavioral health supports that they might need. And the integration of primary care and behavioral health is part of this concept. I hope that helps.
Thank you, Ingrid, and thank you, Rep. Schmidt. We will definitely incorporate the quality question and the question about the safety net if a scenario were to occur where there needed to be a backup for the primary care. Those are both great, and we'll incorporate that into our work. Mohammed, I think you had your hand up as well.
I did. Thank you. Most of the questions that I had were actually answered. So thank you. One quick question. We know how important this work is. Like the commissioner's work on establishing a universal healthcare. Is the September meeting, between now and the September meeting, too short? Maybe to do and figure out everything. Do we need more time? That's one of the questions. Secondly, can we afford? Is this can we afford it? For example. I heard a figure being mentioned from the commissioner's office. So is there enough money to do this work? And is the work basically for the work group between now and our next meeting, which is September 4th? Is that realistic time frame that could be delivered? Just those are my questions. Thank you.
I really appreciate that question, Mohammed. It's something we think about frequently, is whether there is time and capacity to be able to address those. Would like to open it up to work group members to see if they have any thoughts, and then happy to follow up.
Can I chime in? It was actually why I raised my hand.
Of course.
Thank you, Mohammed. I'm sort of struggling with, because some of the questions and some of our decisions is sort of like the chicken and the egg. And then what's our role as a commission? So let me take those two statements apart. The first is, what's our role? Our role as a commission is to stay, in my opinion, everybody else can have a different opinion, obviously, at the 60,000 foot level, not to actually build the plan, but to say, give a blessing to whether it's the Office of Insurance Commissioner or ACA to build the plan for us and come back. And then put, like, for example, I really, really liked Rep Schmick's comments and questions because I wanted to second those, you know, taking into consideration things that like metrics as the plan is built and how are we going to measure this and what are the transitions, sort of we help put the boundaries on, and then someone else puts the plan in place. And then, you know, I guess to get my second point, if we are not doing the plan itself, do we have, what's the information we need to be able to say, give blessing to go forth and make a plan and come back to us? And that should be our questions. What is going to make us comfortable to do that? If my first assumption is correct, which is we're supposed to stay up at this level and someone else brings us back a plan once we say, go forth and make it. What is the information we need to have that decision instead of the details of the plan? I guess that's my point.
Fantastic points, Representative Parsley. I know that those are all items that are kind of on the table in that the work group is considering. And I know from a staff perspective of supporting the work group, certainly we'll continue to work with them and check in and inquire about whether they feel that they have sufficient responses to the questions that the commission has raised. And I guess that will be a process that will play out over the next few months before we get to that September meeting. Again, open it up to work group members if they have anything additional they'd like to add in response to Mohammed or Representative Parsley's comments.
Ross, if I may, Mohammed, I would say that definitely by the September meeting, all of these questions will not be answered. That it really takes time to build out a complex model such that we're talking about. So what I would say would be needed would be perhaps direction from the legislature, and then the opportunity for commissioner to dedicate more regulatory account funding so that we could truly have the container that we need, and potentially contracting out for some professional analysis, working with this work group and this commission, and then come back to the legislature with a more fully fleshed out plan and some implementation ideas. That kind of work takes quite a bit of time. I think the decision point for September is just the interest level of the commission of being the place where this is really grounded, this work, and how it connects and links to the broader direction of this commission to build a universal healthcare system.
Thank you, Ingrid. Especially appreciate the honest answer that realistically, probably not all of those questions can be answered in that time. And just wondering to Representative Parsley's question about ultimately what information would the commission need to be able to make a determination on this question of incorporating universal primary care into the work plan, and wondering if it might be a helpful exercise for the work group to potentially highlight the areas that might diverge from what our current work plan is, or what items might require separate analysis that might not apply to to our current work plan. OIC had a great slide highlighting that all of the elements will be covered under both universal primary care and with the full comprehensive universal health care, but maybe spending a little time trying to think about what might be different. Would that be helpful in terms of informing the commission's decision?
Joan had her hand up.
Joan? Yeah, hi everyone. Ross, I took my hand down because you asked
Sorry.
my exact question just from a practical work planning perspective, which is, I think, understanding where and how this work would maybe impact the work plan would be helpful. I think it's an interesting policy idea. I'll admit to not knowing much about it. I connected with Laura Kate since I had to miss the last meeting, and Leah's here. We have some good thinkers on health policy and cost containment, and we also have some folks who. So I'll huddle up with them in advance of the 3rd and provide some sort of more feedback in this forum. But the things that were top of mind for me were just impact on our current work plan, and then also potential overlap with other committees and commissions. Hiroshi, I was going to ask you if that came up in the work group meeting at all. I was just thinking, I see the nexus to sort of some of the universal principles where we're thinking about, and Ingrid, fully appreciate the, like, we need a space, or, there needs to be a place to have the dialogue that moves the idea forward. So hearing all of that, and then just thinking it would help me to understand, like, I know the Healthcare Cost Transparency Board does work on the 12% cost reduction. I know that cost savings was an issue that several people mentioned, and I feel like that's sort of veering a little, that framing veers a little bit into their lane, that the universal framing veers a little bit into our lane. Just wanting to understand where our expertise sits relative to maybe where there's expertise in the state. We're already working on universal primary care design. And if, and how we could sort of mesh it together or find a home for this topic that makes sense.
Yeah,
Thank you,
Joan.
Joan.
Yeah, Joan. Yes, we did talk about that, and we're very cognizant of the fact that we don't want to duplicate work.
Yeah.
I think the idea is where do you find a home for this work? Because everybody's sort of looking at it from their own lens of whatever their topic is. And so I think one of the potential advantages of it being here in the universal healthcare is because we did talk a lot about it being as a fundamental step. And so is really integrated in the design. When you go back to the slide that I think Ingrid was referring to, that Jane had put together, there's so many fundamental questions that have to be answered that is already part of the work plan of this commission. And so there's a lot of things that we can somewhat, take it as an assumption, either because it's been discussed at one of the other commissions or it's being discussed here or be figured out here, rather than trying to start this thing from whole cloth.
Thank you so much. And again, Joan will work to incorporate those questions into what the work group is contemplating over the next few months. Vicki, please go ahead.
I think Senator Cleveland had her hand up a little while ago. Did you get your question answered?
Thank you, Madam Chair. I appreciate you calling on me. Well, I appreciate this good discussion, and there and I am just keep coming back to a more overarching question that I wonder whether we wouldn't want to include in any kind of framework that is developed moving forward, and that's being really explicit around how access to primary care would be improved through this particular type of system. So would just want to ensure, and maybe it is here and I just haven't seen, or it didn't jump out at me. But the other thing I'm curious about, on page 60, there's a bullet that refers to attribution or assignment of patients to practices. So the other thing I would call out simply that I'd want to learn more about or have included in any sort of framework that's built out is just how patient choice is handled. So those are the two things that are important from my standpoint.
Thank you, Senator Cleveland. We will incorporate those questions. Chair Lowe, back to you.
Yeah, and so in the Indian healthcare delivery system, I mean, people go to the clinic that's closest to them, basically, right? But then we have like a reporting process and this 3-year look back. And I think something like that might be helpful to make sure that the right clinic is getting paid for the patient. Because people do tend to like maybe get mad and go to another clinic, or they're out of town and go to a different clinic. So how would all that be handled? I think there's a lot of things that we do in the Indian healthcare delivery system that could really help inform this process. Like, we have we have a user population reporting that we use, and then each clinic or provider gets so much per member per month and mind you, it's grossly chronically underfunded, and that's the problem. Less than half of what you get for Medicaid is what we get for Indian Health Services, so that would have to be addressed. But the bones are there already too. So I think access to care is, as long as we're have providers and a choice of providers, making sure that we're looking at different levels of providers, nurse practitioners, physicians assistants, all that, like a care team. But as we invest in primary care, I think we'll bring more people back into it too. But anyways, I did want to point out the similarities between this and the Indian healthcare delivery system. Thank you.
Yes, thank you, Chair Lowe, and turn it to Representative Schmick. Please go ahead.
Yeah, I just had one thought. I was thinking about this. How is this going to get more doctors into an already severely short workforce? I'm thinking about in a rural area, we can change the whole system, and yet if we don't have enough doctors, we don't have enough doctors.
Yeah, I think I could talk about that a little bit. And some of the elements, I think, on one of the earlier slides about a couple different things. One is just the whole concept of administrative simplification. I can tell you in my past life as a healthcare administrator, we ask our doctors to do a lot in terms of documentation, in terms of just providing information for either ourselves as a health system or to the insurance companies, right? And so I think a lot of the benefit of doing something like this and potentially changing the way that they're paid helps eliminate a real rock in the shoe, so to speak, for providers. I think the other thing when you think about the goal of increasing primary care spend to 12%, a lot of dissatisfaction or a lot of choice about where providers are going to practice starts after med school. And they have to start making decisions about what specialty am I going to go into. And you look at the average compensation of pretty much all forms of primary care specialists versus specialty physicians, there's a wide gap in compensation and income. And so, people being generally rational economic folks, they may pick the higher income specialties over primary care. So I think that when you combine a lot of those things, that's kind of how workforce gets addressed. We do know that I think like Swedish recently announced that they were going to drop the number of primary care slots in their residency program. So it's a current problem, and some of these things that when we start talking about improving the life of a primary care provider can help address those workforce issues.
Thank you. And I think Rep. Parsley, your hand is up.
Thank you. So while I'm a veterinarian, I'm not a primary care. My sister is primary care, and she's actually working in Oregon on the same issues. And I had opportunity to speak to her and two of her friends about this very issue, because how do you get the workforce? One, she pointed out we should be not just looking at MDs and DOs, but PAs and nurse practitioners so that we fill out our workforce. But two, when they've looked into it, and she was on the ACP executive board, they were looking at retention of primary care. One of the big factors is the difficulty of practicing as much as reimbursement. So the joy of doing medicine in a system where you're not always being second guessed by an insurance company and you're not sure what you're going to get reimbursed every time you submit for reimbursement, those kinds of things. If universal primary care can solve some of those, it's a quality of life thing that you might start seeing people want to do this work more, because some of these, shall I say, the death of 1,000 cuts for some of these folks and the joy of being in medicine.
Thank you so much for all the comments. It's been incredibly helpful. Vicky, I see your hand up. Please go ahead.
Yeah, I just want to add that, we didn't get here overnight. And so to get out of this, we're going to have to, make some major changes. And that means that when we're like looking at our progress, we have to really consider what is actually progress and that it might be a longer road. So, not immediate access for everybody to primary care. That would be awesome. But we do have to build that back up.
Thank you, Vicky. What a pragmatic thought and very true. And I guess I'll just give a quick shout out. Our Primary Care Advisory Committee and Advisory Committee to the Healthcare Cost Transparency Board will be meeting next Thursday. And we're inviting Renee Fullerton from the Workforce Council to discuss this issue specifically related to primary care providers and what strategies we should be pursuing, both short and long term. So very much related to this conversation. So encourage folks to look for that as well.
Thank you, Ross. And I want to say, so thank you to all the work group members, and thank you to Hiroshi for joining us. I know you're good till 3:30. Just about one more minute. So we really appreciate your joining us today and helping with the report out and fielding the questions. Want to bring us back to this nice blank next step slides where, listening to the conversation and thinking about some of the big questions to come back with in September. I think there's still a lot of detailed questions. And I think it was Ingrid who mentioned that, these things aren't going to get fleshed out between now and September 3rd. But we know the questions are there. Folks know the questions are there. They will be addressed. It sounds like the big questions that commission members want to hear are, how would this affect the ongoing work plan? I mean, the picture I showed earlier, how would it affect the ongoing work and mission and work plan of the Universal Healthcare Commission? And I think another fundamental question is the commission the right place for this idea to live? Leaving aside the details of the idea, people mentioned the Healthcare Cost Transparency Board and other entities within the state. Is the commission the right home? And do commission members want it to be the home? Please jump in and let me know if there's other questions or if I didn't quite hit that. Nicole, hi.
Hello. Kind of what I was iterating when we met the other day is I do think it's the right place for this work, just because we're kind of a nexus of all the different groups that have met. Healthcare Transparency Board, there's like a bunch of different groups that are studying, how to make healthcare more affordable, but this one is about universal access. And so I think it's a good spot.
Thank you. Is there another hand I'm missing? Representative Parsley.
I just have to echo Nikki, especially if the plan we're looking at could be checking off boxes we need to check off with the whole plan. It will give us the experience and the trial and error that we need to build it.
Thank you. Are there other, there you go. I was about to ask if there's other fundamental questions, and I see your hand, Vicki.
No, I was just agreeing about this commission being the place for the work. I mean, we can't work in silos, and it's got to come together somewhere. And it makes sense that this body, because of all of the different sectors that are part of it, but also that we have the legislators, I think is a good place for it.
And if I
They
could
do
just
think-
echo, thank you. I just want to echo the comments that are already made. The Office of the Insurance Commissioner, I'm also Commissioner Cooter's delegate to the Healthcare Cost Transparency Board, and there's good synergy there. And I'm so grateful for the work of Dr. Judy Zerzan and that primary care work group. But again, the focus of that commission is really about containing healthcare costs and the cost growth target. And this commission is uniquely about expanding access to all, not just coverage, but access. So I think there's enough synergy between the two, but this is really the most fitting home for this. And as the work that we need to do for the long haul to develop the full roadmap for a universal system, this would expedite that and hopefully create more space and capacity to do the homework, if you will, that needs to be done. Many of the questions asked will not be answered by September meeting. The question is, does this commission want to invest in the time of being the home and getting the resources so that we can answer those questions?
Thank you. Sorry, I'm catching up with notes.
Mary,
Dr. Condit.
I also heard that that it might be helpful to have another work group meeting, at least one more work group meeting to maybe go through the question.
Thank you.
And we talked about how there was a framework, and so maybe it is having the work group rather than developing a framework and asking how it fits, to maybe to put some thought into describing how it would fit potentially, and putting that forward, and then maybe just capturing questions. And I think there are a lot of questions, just thinking about which ones are necessary, to Parsley's point about going forward at this point, to making a decision about going forward at this point. And maybe the work group could be helpful in framing that up.
Thank you, Jen. And Dr. Quanget, your hand, I see your hand.
Yes, thanks. I just wanted to check my understanding of what we mean by having a home. And do I understand things right, that having a home would be having a home for the design? Because I could certainly see this commission being an appropriate place for design. But if we're talking about implementation, that's I guess I want to think more about that, because obviously if it's going to be a very long-term, very long, hopefully expansive road if we get to that point, and so implementation operation, I'm not sure what the best home would be. Thanks.
Thank you, Dr. Quanget, and think. Just looking at our enabling statute, the commission's directive is more so the design, as you noted, of preparing the state for a unified financing system. So would assume as well, if direct primary care was incorporated, that we would still stay with the benefit design, and then ultimately let the legislature make that determination prior to moving towards implementation. So believe that would be just limited to the designing of a universal primary care benefit.
I appreciated the suggestion, Jennifer, that you had, is to have the work group meet again. So there's a more specific proposal that will be voted on in September.
Thank you.
So we can make sure that those of us on that work group, make sure that gets scheduled and happens.
I'm not seeing more hands, and I know we thank you all very much. This is all very helpful for framing, helpful to know what we need to bring back at the September meeting. So we really appreciate that. And again, work group members for your time outside the meetings. It's very valuable and helpful. And Vicki, I think I'm going to send it back to you.
All right. Thank you, everybody. That was a great conversation. And thanks, Hiroshi. He may already had to go for joining us today, and the work group members for the time you put in and what you just committed to. So our next item is a discussion about how to apply the Office of the Insurance Commissioner Proviso Funds. I'm going to turn over to Jen Scott, the Senior Policy Analyst for the Healthcare Authority, for that conversation. Jen.
Hey, Vicki. Next slide, please. So today, just going to do a quick overview of what the proviso is, and then review FTAC's input from their most recent discussion on the topic, and then review the details of 3 proposals for analyses using the OIC funds that have been put forward, and then we'll end with some time for discussion and a vote. Next slide, please. So just a quick review, that OIC proviso is $250,000 provided by OIC to support economic, actuarial, or other modeling related to the design of a universal healthcare system. Just wanted to highlight that the money does need to be spent by June 30th of next year. So the time's coming up, and it definitely would be important to begin work on this soon, which is why we're asking for a vote today on the topic. Next slide, please. So at prior commission meetings, this has been discussed a few times. The commission requested that the analysis topic focus on financing or provider reimbursement. And then at the last meeting also asked that if it could address both universal primary care and universal healthcare, that would be preferable. Suggested areas of inquiry, kind of high level, are the cost for universal primary care and the full universal care system, and then looking into any overlap that may exist between those systems, and then also identifying potential funding sources. Next slide, please. At the last FTAC meeting, input was that it's challenging but not impossible to double dip and have one analysis answer questions about both universal primary care and universal, an eventual universal system, and that the topic should be clearly connected to an analytic question or test a hypothesis that will inform system design decisions. And then to make the best use of the funds, we should avoid questions that could be answered already by data that we have in the state or that our staff could analyze, and should focus instead on those that require external actuarial or economic modeling expertise. And so as Mary mentioned earlier, following that FTAC meeting, staff summarized 3 of the ideas that had come up in prior FTAC and commission meetings, which seemed to best meet the recommended approach and focus areas from both FTAC and the commission. And these proposals were emailed out to FTAC for any additional thoughts or tweaks before we move forward with them. Several FTAC members expressed support for specific proposals, and some provided some extended comments. We have included those in Appendix B. So I am going to briefly walk through the 3 proposals, and then we'll have time to discuss those in more detail at the end and ask questions, and before moving to a vote on how to use the proviso funding. Next slide, please. So the first area of study is modeling costs of different administrative structures, potentially drawing from the experience of other states. And the structures could include, but aren't limited to, would we be looking at fee for service or managed care payment, a state-run or a third-party administrator, and then some interest in looking more into Connecticut's model for Medicaid, where they have moved to state-administered managed fee for service. And this study could help to shape the infrastructure of a universal system and could inform questions for some of the outstanding topics about, are we thinking about a single versus multi-payer system? What is the role, if any, for insurance carriers, and which entities would be taking on administrative functions? So could address 3 of our elements: financing, infrastructure, and governance. In terms of the votes, 2 FTAC members. So not everyone voted, and it wasn't an official thing. I'll just say that people who wanted to make comments sent comments via email. So 2 FTAC members did follow up with email to endorse this option as their first choice, and another said it was their second choice. And then a member suggested combining this proposal with the next one. And there's more detail on that in the appendix. Next slide, please. The second area, I believe this was Pam McEwen's suggestion, which was to test the hypothesis that spending 12% on primary care saves money elsewhere in the system, and if so, how much is saved. So this ties to the idea that that primary care is out of balance with other more expensive service types, and that there is money to save if people are seen in primary care, that their healthcare is going to be less expensive overall. Maybe not going to the emergency room, getting things caught earlier so that they don't require more costly services. And so testing that, and then that money would potentially be available to fund the universal system in some way, not 100%, but to contribute to it. The result could help to inform both cost estimates for universal primary care and the eventual universal system. And this would address the elements of financing and also the universal primary care question. 3 FTAC members followed up to endorse this as either a first or second choice. Next slide, please. And the third one, a little bit less analytical in terms of numbers, is to develop a strategic plan and timeline for transitioning from universal primary care to the full universal system. And this was raised at the April Commission meeting. The results could help inform whether to pursue universal primary care and how to ensure a smooth transition to a universal system. So looking at that question, the table that Ingrid spoke to about how does primary care, universal primary care, potentially serve as kind of a test case for the full universal system. And this would address enrollment, infrastructure, and universal primary care. And 1 FTAC member followed up to endorse this option. Next slide, please. So I just wanted to start by saying, are there any questions about these proposals? And then knowing these aren't the only ideas, are there any, does anyone have any additional proposals or amendments that they would want to suggest for consideration at this time? Vicki?
But number 2 about the 12%, is that something that the Healthcare Cost Transparency Board has looked at, or do they have they already studied that some? Do we have some information? I know this.
We do have, so that's part of the cost growth against the benchmark data that's collected. So we know that we're, I think, below 6% right now.
Oh, yikes.
So,
no wonder.
Yeah, and it hasn't been getting better. That's what the Primary Care Advisory Committee, which reports up to the cost board, is one of their main charges, is to think about strategies for improving that balance between primary care and the utilization of other services.
Thank you.
Rep. Schmick?
In the proposal number 2, would this also include compare and contrast? I know that we're only like 3.8% spend on primary care, so it's hard to compare. But will it also take a look at what we're currently spending? What is this overall going to cost the system? Instead of, I know that's intended to focus on what is will save the overall system, I would say I've been in the legislature long enough to know that I'm skeptical of these type of studies because frankly, we hear it all the time. Well, if we just do this, we'll save all this in the future. And so the more validity we can bring to this and data, I think the better decision we can make.
Just to clarify, are you saying that it should also identify the cost of universal primary care as part of the analysis?
I think it needs to include what current spend is.
Oh, okay.
And include what currently is happening. And I also would like to see some concrete ideas about how we're going to have more people in the field for primary care, because we can plan to do this all day long, but if we don't have workforce, we don't have workforce.
Yeah, and I do know that the Universal Primary Care Work Group is working on a couple of recommendations related, and one of them is going to be about how to improve the workforce. Any other questions or thoughts?
Hey, this is Dave in the room, so I don't get to raise my hand virtually. I could use a gentle reminder as to which, if any, of the three proposals most align with comments received and letters received from our external advocates that are paying very close attention to all of the commission's work. And I would just appreciate a reminder as where alignment on advocate feedback is on these three, since the FTAC proposals were split endorsements.
I will try to paraphrase what folks have said. I would say the comments that we have heard from advocates are reflected most in number one. And if you look down the left column, it's talking about costs of different administrative structures. And then it's, include but not limited to. So those three sub-bullets, it's sort of three different ideas. And what we hear very often, goodness, I hope I'm paraphrasing this correctly. What we hear very often is a very strong interest. I think we had a comment on it today. Connecticut's model of deprivatizing Medicaid and going to an ASO model and not going through the MCOs, state administered managed fee for service. And we also hear a lot of support for models that remove the carriers in some way. So I would say, and again, I know other people sit in on these meetings, please jump in if I have this wrong, that the three ideas in number one are perhaps more reflective of what we hear, particularly the bottom bullet.
Thank you for that gentle reminder.
And I'll just add, while folks are thinking about any other questions, just at a high level, this was funding that we received in, I believe it was 2025. I could be misremembering, but we have 2 years to utilize those funds. And so we need to spend these funds by June 30th of 2027. So the reason that we're really presenting these today is because the goal is that we can make a decision on which area to focus on so that we are able to do the contracting with the external contractor that's necessary, conduct the work, and complete this project by June 30th of 2027. Although it seems like nearly a year away, between the contracting process and working with economic or actuarial firms, it does often take roughly that long. And we just want to be mindful and grateful to OIC for the proviso funding and just making sure that we're making good use of these funds. So just want to remind folks of the necessity of making a determination on this hopefully today, so that we can begin movement on this in between now and the next meeting.
And also, I just wanted to mention, I believe we decided that FTAC is going to be the group that's essentially the work group that that when we're working with the contractor on the analysis. So, so there, this, for example, number one, those are examples of what the analysis could look at, but there is an opportunity to, you know, to kind of shape these up, and I think they'll be. This isn't exactly what the analysis will look like when we have, you know, more interaction with the contractors to make sure that we have a clear question before they start working on it. Sorry, Nikki.
The proposal from the FTech member who was thinking of combining 1 and 2, does that encompass all of study area 1 and only parts of 2? And is there enough funds in order to cover all of those topics?
So I could just read, it was Sarah Hewling. Her idea was, oh yeah, she is here. Okay.
Sarah,
That would be good to.
Sarah Hewling is a member of FTAC, and I believe this was your suggestion, Sarah. I think you can unmute yourself and let me know if I got that right, that it was your suggestion.
Hi, yeah, it's a magical suggestion that somebody's gonna make happen. Sorry, let me get my camera on. I was investing in my own health by walking on a walking pad. So, you guys can see my email, and if I guess I'm not fully prepared. Because this is new because I looked at it today, the way this is presented, but can we see the number 2 as well, please?
There's actually a slide at the end that has all 3 on the same page. Maybe that would be helpful. Yeah.
Yes, ideally it would. So number 3, I guess I feel like I'm all 3 of those, if I were to be fair about my suggestion, because it's dealing with the 12%, and the 12%, from my understanding, is a requirement through the Cost Transparency Board, and thus makes sense to incorporate in addressing primary care, since it's, correct me if I'm wrong, a legislative requirement. And then the other members were bringing up from the FTAC were bringing up all these sticklers around fee for service, and then the administrative burden, as well as looking at other models. And so does that answer your question? Thank you.
It does. Thank you.
And Sarah, I actually highlighted a couple of your comments. You said that that analyzing number one, if we consider universal primary care as our foundational phase 1 implementation, analyzing its financing is analyzing the first phase of the universal system. The mechanism we test will serve as a financial architecture for the larger system, and then combining the administrative modeling idea of number 1 with the cost containment testing necessary for idea 2 was kind of the rationale for combining those 2.
Well said.
Ingrid?
Brent Parsley, did you have your hand up as well?
Oh, I'm sorry.
Oh, mine's, I hate to ask this almost, is basically a year enough time?
Well, that's a great question, and I am assuming here, but in the past we have generally been able to get these types of products back within 6 to 9 months. So those additional 3 months, would be on the front end with us establishing contracts and doing that part of it. So hypothetically, yes, but we are running up on a pretty tight timeline here, but we should be able to complete it if we're able to get a decision on this today.
Jump in for 1 second. A lot of our assumptions about timing and how we go about this, and Jen mentioned that it would be an FTAC work group, digging into the details and working with the outside contractor. It's based on our experience in late 24, early 25, a project that was proviso funded where Milliman did some analysis. So we're just we're going on how long that took and how the logistics went and working with FTAC and sort of applying that model this time around. And this project that we're talking about now is not necessarily Milliman. I'm only mentioning Milliman because they're the people who did the work last time around.
Thank you.
Ingrid, did you have a comment?
Oh, yeah, thank you. I just want to note that OIC is defers to this commission overall for the use of these funds come from our regulatory account. And I want to note that $250,000 may sound like a lot of money, but when it comes to these kind of projects, it is not. So it may not be realistic to try to do each of these 3 bodies of research for that amount of funds, just a thought. And then I was like noting where the FTAC members, where the endorsements came, and it looked like quite a few were on number 2, and then also on number 1. So there could be a clever way here that has already been suggested to combine. You could look at fee for service versus a per member per month payment, and look at those different models and understand what the outcomes have been for models in which there are current populations who are the 12% of their dedicated fund, the funds dedicated to their healthcare are for primary care. So there's a way that you could tease this out by looking at not only primary care, what is the impact? Longitudinally, like looking ahead would take longer than we'd have time for this study, but looking at existing models. So whether it's direct primary care or some of the Kaiser model more so than others, the kind of models that already exist where people have better access, what is their impact on downstream costs of hospital care, et cetera. So that's just a thought. And I think appreciate the commission making a decision so that this can move forward. Thank you.
Dr. Quangate?
Please call me Tao. Option 2 appeals to me because it's a focused, concrete question that seems answerable within the time that we have and within the time and budget that we have. And I also like Representative Schmick's suggestion that it also compare our current spending with 12%, with what might happen with 12%, because I think that could be useful information for many parties. I feel that option 1, I'm concerned that there's not enough time to really do a thorough job of modeling so many different options. And then to me, option 3 seems a little bit premature. It seems premature to develop a strategic plan and timeline to transition from universal primary care to a full universal system when we don't even have a strategic plan and timeline to transition from our current system to universal primary care. So that would be my 2 cents. Thanks.
Ingrid, did you have another?
No, I'm attempting to put my hand down. Sorry.
I think Joan's hand is up.
Oh, thank you. And I'm sorry that I'm going to have to drop off right after this. I have a conflict I can't get out of. But yeah, I agree with similar comments to the ones that were just spoken. I think I also felt like 3 was a little premature. I appreciate the FTAC feedback and the advocates' feedback on 1 and 2. Ingrid, I was going where I think you were going, whether you do it 2 with a side of 1 or 1 with a side of 2. I was kind of hoping that we could advance the discussion about the delivery model, which I think is just something we've been asked to do and it's been swirling for a minute. But with a slice or with a narrowing of that analysis to really look at which one better advances the ability to reach that 12% primary care spend. So I was also, as we all want to do, mash up and get everything magically. And I endorse everything Ingrid said about the $250,000 not being like what anyone would want it to be. So anyway, Ingrid, I also had a question about whether we think there's a chance for for additional funding to support the universal primary care work if we go in that direction and adopt it as part of this work. You know, if we're able to get something that further boosts that work. Anyway, didn't know if this was a one and done to sort of support that funding or that work, or if there was a need to advance that sooner rather than later. But I kind of like getting at a little bit of the delivery model with the lens toward toward number 2.
Senator Cleveland.
Thank you very much. I'll just share the factors that are really compelling to me in this discussion is that, due to the really short time frame that we apparently have to utilize this funding, and due to the majority of FTAC members were clearly supporting option 2, and due to the fact that the legislature has actually directed the 12% goal of total healthcare spending to meet the 12% range eventually, it really seems to me that it's demonstrating some consensus here. And so for me, I think the current most valuable analysis to inform our focuses moving forward would be option 2.
And thank you for those comments. Wondering if hearing some consensus building around option 2, as well as some interest in trying to get as much out of this analysis as we can with the 250. Just thinking about proposal 1 and how we might combine those. Would there be openness by the commission to allow staff and FTAC, if we do choose proposal 2, to work with the contractor to identify the most cost-effective way to model some different administrative structures, my understanding being that that would inform decision-making. Once we get to administration, do we want TPAs to be involved with the universal system? Do we want that to be, state-run, public-private partnership? And that some of the cost analysis associated with these different structures would help inform that decision. If we were able to work with a contractor and they could provide, some cost-effective method of giving us a high-level understanding of costs associated with the different administrative structures, along with proposal 2, would that be an acceptable way of combining these 2 proposals? Yeah, Dr. Tao, please go ahead.
Yeah, thanks. Well, I wonder if perhaps an option might be for the main goal to be assignment to be option 2, and if the contractor does a really efficient, quick job and answers that question and has additional time, then the extension might be, well, for option 2, how does the different administrative structure impact the amount of money that primary care, that a 12% primary care saves elsewhere in the system? Thanks.
Thank you. Excellent suggestion. Representative Parsley, please go ahead.
I just want to give yes to what was just suggested by Dr. Kwan.
I will add in some echoed support there. My experience is if you tell somebody you have $250,000 to answer a question, they will spend $250,000 to answer a question. If you tell them that they have $250,000 to hopefully answer 2 questions, you may actually get more answers than just to question 1.
So, Mary and Chair Lowe, how is the best way to do a vote? It seems like maybe we're moving towards.
Well, I think, is there maybe a motion to combine? I liked, I think what Joan said, number 2 with a side of 1. Would that be helpful if we had a motion? Nikki?
I move for number 2 with a side of 1 with the flexibility for FTAC to, figure out which of that part on 1 they would like to include.
Second.
All right, we have a motion and a second. Is there any discussion? Okay, no discussion, then all those in favor say aye. Aye.
Aye.
Aye.
Any opposed? Say nay. Sounds like a unanimous consent there, Jen. All right.
Great.
Yay.
Thank you. Yay.
We have a plan. Thank you,
Thank you all.
everybody.
Thank you.
And we will begin this process of trying to identify contractors and getting to work on that. And we'll also bring back routine updates so that hopefully, maintain transparency and communication with the commission, as well as getting feedback when needed. As we noted, there's a little bit of give and take, incorporating proposal 1 into 2. So appreciate the time and energy to kind of get through this today. Thank you.
And Ross, a clarifying question. The contract will go through HCA. The funding's going to you guys in your contracting, or is OIC doing the contracting, or will you work together on it?
We intend to work together. The proviso language encouraged us to enter into an interagency agreement. Provided that's the most efficient method, we'll pursue that and work with OIC in terms of, finalizing with the contractor.
Okay, thank you. All right, so we have a 10-minute break scheduled. Should we come back at 4:18? Mary, is that sound good?
That's fine.
Okay.
Saying we're right on time.
4:19. Yeah. See you back here in
Apologies, I
10
won't be
minutes.
able to return for the last section.
Okay. Thanks for being here, Ingrid.
Yes,
you, Ingrid.
thank you
Welcome
all.
to the
Excited
group.
to work with you more. Okay.
Bye. All right. See you all in 10 minutes.
10 minutes.
Good afternoon, all. We will be starting back at 4:20, so just one more minute here. Great background, by the way, Vicki. Really like that.
It matches my earrings.
That's important.
It is.
Vicky, I may have to head out before the end. And I'm
Okay.
sorry, is there a vote? Do you need are we going to be doing a vote on this section? I read through it and it didn't look like it.
There is a potential vote in this section, but certainly not as mission critical as the OIC proviso vote. So certainly feel free to take off whenever you need. Thank you.
Thank you.
I also need to apologize. I need to leave shortly before 4:30. Thanks.
Okay. We will see if we can get our potential vote in under the wire. But yes, understand that we're also coming up on a long weekend here. So, people have places to be. Completely understand that.
And
I
just-
see. Oh, go ahead, Ross.
Just to clarify, Harrison, there may be a vote today, but this proposal, the provider reimbursement proposal, will come back if folks are not able to participate in the vote today before it's finalized. It will come back. Is that right? Or
That is right. We'll come
Okay.
back at least at some point, depending on sort of what exactly we're talking about. But certainly this will not be the last time this body sees or is able to adjust this before its final form.
Okay, thank you.
Okay. Are we all back? Let's just get into it. So, welcome back from break, everyone. We are going to talk about provider reimbursement. So, next slide, please. So before I talk about the specific documents, just again, a quick orientation to the main work products here. The guiding principles document sort of forms the foundation of these documents, and that was something that was approved at the last commission meeting. We also have two other work products that are working their way through the pipes here. We have the proposal, which is really sort of the core of these documents, and then a roadmap proposal, which is a little bit more descriptive. And you can find these in the appendix. So Appendix C for the proposal, Appendix D for the roadmap. And today we're going to be talking about the state of those remaining work products. We'll have a chance to review proposal edits. So the last time the proposal was in front of the commission, provided some really helpful feedback, and FTech and the work group have implemented some changes to that. So giving a chance to review that, a potential vote, depending on how many folks we still have around. And then after that, getting into the new document, the document that's making its debut, which is the roadmap document. Next slide, please. So a little bit more about what these documents are trying to do. The proposal is providing sort of the basic structure. So recommendations for payment mechanisms that could be implemented narrowly, and then implementation strategies to broaden those strategies. Then also recommendations for provider participation, as well as how data should be collected, how it should be used and overseen as part of this payment model and these new payment strategies. The implementation roadmap, on the other hand, puts things in order. So we have, as part of that document, two implementation pathways that are pretty descriptive, certainly could be more descriptive, but they sequence the mechanisms in order, and they also provide a couple other details, things like potential federal waivers that might be needed along the way. And then also something that we're building out is evaluation of these mechanisms and how they might impact communities as they're implemented in different contexts. And that would be with respect to the guiding principles, sort of coming back to our foundation. Let's go to the next slide. So we've talked about the proposal before, but just again, a quick orientation to what these sections are. A summary background covers a bunch of things, but really importantly grounds us in why this document's talking mostly about transitional solutions. And the takeaway there is we're talking a lot about transitional solutions because one of the first steps in terms of getting towards universal coverage is getting our arms around cost containment first. We know that the spending in the current health system is very high, and these are strategies that we're describing to get our arms around that and begin to address that first. So we have two different payment we have different payment mechanisms that we describe primarily around spending and price regulation, and then also a separate set that describes how we can begin to or continue to leverage state purchasing power and expand our use of open competitive contracting through a variety of different strategies. Again, we have those other sections as well, provider participation, having sort of two phases, an early and a late phase. The late phase including really mandatory participation for providers. And then that oversight and data collection section really gives us grounding in terms of where we need our data systems to go to best support these payment systems as we build them out. And of course, alignment with all of the other work that's going on in the state. Next slide, please. So again, in the last commission meeting, we received some really helpful feedback on that proposal document and orienting you now to the different edits that we've made to address them. One of the big ones that we heard in the last commission meeting is some concern around implementing especially reference-based pricing in rural facilities. And partially due to those comments and also really some deep conversations we've been having among the work group and FTAC, we, especially to align with current state policy, have changed the document so that the rural communities are no longer sort of the tip of the spear when we're implementing these various payment mechanisms, whether it's reference-based pricing or hospital global budgets, but they're rather exempted, at least for the time being. And inclusion of those rural facilities may be addressed in the roadmap document as we have further questions about how to address these concerns with sort of low volume and rural facilities, or it could be subject to a decision by a future governing body, of course, to be determined by the governing section of all of these design proposals. We've also, just to clear things up, pulled the sort of background about distortions in the fee schedule up to the top of that section so that there's no implications of, one specific payment mechanism being a panacea for those distortions. In the provider participation section, we received some feedback, some questions essentially of, is mandatory participation really necessary? Is there any possibility to allow an opt-out in that phase? FTAC discussed this, and the conclusion that we came to essentially was allowing for opt-out at that phase would very likely allow your highest spending providers to opt out, and that would very much jeopardize cost containment goals. So the recommendation here is to have that last phase really be a mandatory participation phase. And then in the oversight and data collection phase, due to some discussions at FTAC, the work group, and with the commission, we've added some additional detail looking at the current data sources that could be sort of pulled together and ways to sort of channel those different sources towards a unified source for sort of a one-stop shop for payment data. So this payment data could be used for a variety of means. Those are outlined a little bit more in the proposal, but overseeing rate setting, overseeing and evaluating how these payment strategies are being implemented and any sort of knock-on effects we're having in the system, things like that, as well as, of course, research and other goals. So with that, we can go to the next slide. Here is our potential vote. We might have made it under the wire for having a few folks around still. So it's not necessary to have a vote here, but it is a potential to continue to move forward these work products as we are hoping to get to our next design element by, let me see, to start that next design element essentially in the next commission meeting. A little bit of background here. FTAC has not formally recommended this proposal to the commission, but our discussions in FTAC have really shifted to focus primarily on the roadmap and that discussion I alluded to earlier about how to best sort of thread the needle to consider potential impacts on rural or low resource, low volume providers. Is there a certain sort of unifying payment strategy that we could use to address those concerns, or should we sort of continue with the status quo as we've outlined previously? And then also just another reminder that approval of this proposal, whether it's today or later on, doesn't mean it's the last time this group will see it. There will be a process later where we take all of our design elements and sort of reorder them, align them, and make them fit for a final full recommendation. With that, I'll pause. Are there any questions on the proposal itself? Again, this is in Appendix C. If we'd like to, we can also switch to Appendix C on the slides. But opening the floor to anyone to raise their hand or come off mute for specific questions for that proposal.
Can I ask a question?
Of course.
And this may be my simple mind here working. If the FTAC has not come forward with a recommended proposal, how would a vote help? Would it help them direct their efforts towards the roadmap and make things easier for them? Is that what the vote is being asked for?
So certainly it's up to the commission to decide whether to vote. And I think your reading is roughly accurate. You know, it's really hard to know when these documents are done enough, especially considering that we're going to come back to them later on. And the commission really is the body that makes that decision. When we had the potential to vote at FTAC, they didn't quite feel like it was fully there, but as I also alluded to, there has been some shift in certainly which document we're spending the majority of our time on. Does that answer your question? Okay, fantastic. And I see Representative Schmick, you have a hand as well.
Thank you. Have the providers been consulted on this to get their input?
That's a great question. The short answer is, as part of this design process, no. I'm sure that as part of the implementation of reference-based pricing within PEBSEB, providers have been likely part of that discussion and implementation of that. But as we're sort of more in a design phase of this, we haven't had the suggestion yet, but can certainly consider how we may be able to sort of get provider feedback on this document. Wondering if you have any specific suggestions to that end, but the short answer to your question is that is not something that FTAC has done to date.
I just think that with such a major change that you're discussing, you might head off questions later on by involvement now.
Thank you. I think that's a fantastic point. And see, we also have, we have another hand from Rep. Parsley. Please go ahead.
Sorry, so many questions for you guys. When we check in with the providers, because I do like what Rep. Schmick is talking about here, what's your mechanism? Are you working with ACP? Are you working with an association, organization? How are you checking in so that you know you're kind of getting a good survey?
I'll be frank. This is the first time we fully contemplated that sort of level of reach out to providers. So I would have to take that back to the rest of the staff as well as FTAC to scope that out. All ears if folks have specific suggestions. I think I heard one there, but honestly, no plan yet.
And just to add, Rep. Parsley, the body that has been reviewing this is our Finance Technical Advisory Committee, made up of individuals with expertise in healthcare financing and healthcare delivery. And that has been our originating body for some of these technical documents. So more than likely, we would look to receive provider feedback at the commission level, for example, when it's included in these packets. But I really appreciate the additional recommendation to perhaps seek out patient groups or provider groups to get feedback on this proposal as well. So just clarifying at the initial level with FTAC, that is made up of kind of financial experts, but we could look at potentially integrating some feedback from external sources between FTAC and bringing it to the commission. So really like that idea.
Yeah, I bring that up partly because I know there are physician providers groups and primary care provider groups actively working in other states, and they may have definitive opinions, I guess.
That's a great point. And Nikki, I saw your hand. It's down now. Any input?
I know. I keep debating whether or not I want to say this, but like, I also maybe a simple idea would be that they could participate in public comment as well.
Thank you for that. That's an excellent point. Certainly, we hear a lot from the patient groups. Haven't heard from the provider groups as of yet. At least, I'll clarify with my time with the commission. Let's see. I'm not seeing any other hands. Really appreciate the questions and feedback on this document. I'll pause for just a little bit more and kill a little bit more time. If the commission would like, we can motion for a vote. If not, I do have more materials that we can talk through. So hold space for just one more moment before we switch back to the presentation slides.
And I am so sorry for running through these slides.
You're making me dizzy, Ross. All right. I think now would be the time to move on to the, oh, I see a hand from Nikki.
I'm sorry, I was just trying to get back to the right page. So the vote would be to adopt the edits from FTAC, is that correct? Or if we were to motion?
This is correct. Yeah, so the motion would be to accept in its current version the proposal, which includes those edits that I sort of highlighted, but they're in the text that you see in Appendix C, and that would guide FTAC's efforts to the roadmap document. Again, this would not be the last time that the commission sees the document.
I make that motion.
I'll second.
Thank you.
Well, we have a motion and a second. Is there any discussion? Senator Cleveland.
Thank you, Madam Chair. Just want to clarify, this vote will actually approve the proposal and then be formal recommendations, or what is it exactly that we're giving approval for?
Yes,
Just want to clarify.
Apologies for the lack of clarity here. So the approval of this design of this proposal would essentially sort of set it on the shelf alongside the other design elements that are in the rearview mirror. So that would be the status. It would be the same as those others. We haven't fully finished the provider reimbursement sort of section because we have these 3 documents, unlike other design elements. But yes, it would be sort of putting it on the shelf next to, you see, eligibility and the others. So that would be its status. We could come back to it later, but it would be, for now, complete.
And if I could just jump in. Oh, I'm sorry. Go on.
May I ask one follow-up question? Hasn't reference-based pricing been approved by the legislature?
That is correct. I should
Yeah.
caveat a few ways. Reference-based pricing for, as I think we all know, PEBSEB hospitals. To butcher it a little bit, yes, that has been approved by the legislature. So excellent point.
Thanks for the clarifications. Appreciate it.
And if I could just jump in, add on to your earlier answer, Harrison, maybe this will provide some clarity. As the commission approves various proposals and various ways to, various design elements, the things that turn green on our work plan, if you want to think of it that way, we fully anticipate that when everything's green, we go back and there's a reconciliation process to make sure that everything can work together. So as Harrison said, this is not the final look at this proposal.
Any other discussion? All right, so the motion is to approve the proposal with the edits from FTech. We have a motion and a second. All those in favor say aye.
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 Any opposed say nay.
Hey,
Are there only 5 of us here? I counted 5 voices.
And I heard 3 in favor, so I think either way that would be insufficient to approve, if I'm catching that correctly.
I feel like I heard 4.
Oh, sorry.
And then 1 nay. But also just checking really quickly to see. Yeah, we're all that's left. So Mary, I don't know where that puts us vote wise. I mean,
Yeah, I think you're right, Vicky, that we have 12 members of the commission and we don't have sufficient members present to form a quorum to be able to finalize this vote. So apologies, that probably should have been something we picked up on before getting to the vote. But it's helpful to know that there is some confidence in this and we'll continue to bring this back. Thank you.
oh, Mohammed.
Yeah, I'm not sure if I voted because I was changing my audio setting. My headphones ran out of power. So if my vote helps to help us move forward, I would like to add that to the count.
Thank you, Mohammed. I think we're still short, but really appreciate that and definitely can relate to the headphone problems. So with that, really appreciate the feedback here. Really, thank you. This helps the proposals get better, and FTAC really values the input, as do I. So with that, let's go to the next slide. Okay.
I have to go.
So,
see you all.
thank you very much. Bye. To those that remain, we'll walk through the roadmap document now. So this FTAC proposal for a transitional roadmap was something that I think was proposed in roughly January, February, and the Commission accepted that offer. And now what we have is, whereas the proposal is again those sort of building blocks, these this roadmap is really more specific implementation pathways that could be considered. So we have 2 that really comprise the bulk of the document, one on hospital spending and one on sort of expanding state purchasing and leveraging consolidated purchasing. Let's go to the next slide. So an overview of the components of this one. Again, we have those two pathways, and you can see this in Appendix D. It places the mechanisms in sort of a logical stepwise order, sort of ratcheting up and up. It describes how things could be broadened to serve more populations, and it also includes those dependencies, things like federal waivers that might need to be sought. We have several things that are still in progress, and as we discuss the document, please feel free to jump in with any additional suggestions for how this could be most helpful to the Commission. But in our additional work, we're looking at implications, of the payment mechanisms for different settings, as I mentioned earlier, especially rural settings, and especially in relation to those principles that really are grounding the work. So things like a uniform and fair payment system that promotes equity. And so that's what we're aiming towards, and that's sort of what we're evaluating ourselves against. We also have a section that we're continuing to work on that really describes what success looks like. So if we walk down both of these roadways or pathways, whatever they are, what what does it look like at the end, and how might it be better than the current state? That includes things like projected savings, where we can estimate them as possible. One thing that could be included, sort of pending commission decisions that are considerably down the road, might be, including a primary care transitional pathway, and including that as maybe the third that we're considering here. But for now, we're just going to stick with the two, and let's go to the next slide. Okay, so here we're describing the first FTAC proposed transitional pathway. And it starts with sort of where we are now, with the implementation of 5083 in PEB/SEB. I won't sort of go into the depths of what that bill does. I think we're all pretty familiar with it. The next step here could look in a variety of ways. One option would be to essentially bring in other public purchasers as part of that strategy. So fold them into the reference-based pricing fold. And then the next potential step that is proposed is not going directly to reference-based pricing for commercial prices, but rather sort of indirectly affecting commercial prices through capping out-of-network prices. So we know that these prices, have potential impacts on consumers, account for 6 to 9%, I believe, of hospital spend, and this would cap out-of-network prices. And the logic here is capping out-of-network prices sort of neutralizes a negotiating tactic where providers threaten to go out-of-network and charge high prices. Because those prices would then be capped, the logic is that in-network prices would approximate that out-of-network cap. We see evidence for this dynamic with Medicare Advantage. The next step could look like reference-based pricing for the entire commercial market. And once we get to this step, there are other things to consider as well. Definitely establishing a rate-setting body that would really sort of be adjusting these rates, considering all of the nuance here. So that would include rate adjustments, whether we're talking about adjustments to base rates or beyond that. And this could be based on things like hospital type or hospital volume, just to name a few. And then another thing that we could do at this step is to establish essentially a fund or a program to support hospital viability, specifically reimbursing for uncompensated care or addressing that in some way. We know that with HR1, there's a spike in uncompensated care, and this would be one attempt to at least mitigate that in some ways. A final step, which would certainly require a federal waiver, is a potential for all-payer global budgets. And this could look in a variety of different ways. Bob Murray, I believe, has described different options in the past. The suggestion here is for a flexible global budget, one that accommodates some fluctuations in volume. But again, this would be a global budget that allows some control of both price and utilization. Okay. I'll actually pause here before going to the next pathway. Are there any comments, questions, proposed edits to this proposal here? It's outlined in much more detail in the text, but this is a sort of a 1,000-foot view of it. Okay, I'll give everyone some time to think on that. Let's go to the next slide. Okay, so the other transitional pathway that FTAC has proposed really leverages state purchasing power and different ways that programs can be tied together to maximize that. So the first suggestion here would be to merge the PEB and SEB risk pools and to engage in open competitive contracting. We can discuss exactly what that is, but essentially selective procurement for those PEB/SEB groups. Subsequent to this would require, as we're currently suggesting, a few different federal waivers, but we could also engage in open competitive contracting for Medicaid and CHIP, so sort of expanding to other state programs. And following that, we could do open competitive contracting for MCO procurement. I should specify for exchange plans. This could look a variety of ways, but one way to maximize this impact would be to obtain a federal waiver to limit exchange coverage to just the public option and implement it there. And then lastly, sort of the culmination of this would be to integrate state purchasing by conditional selection. So essentially not necessarily merging these all into one pool, but conditioning selection of one on the other to, again, sort of tie together purchasing power. At this point, there would also be the potential for a standardized platform that may drive down administrative costs for the programs we're discussing here. So I believe if we go to the next slide, I think that's it. Would love any questions, any potential edits to this roadmap document. This is something that the FTAC initially proposed, and would love to make it as helpful as possible for commission members. And I will, mention this is not the last time we'll see the roadmap document either. These will come back in September, so we'll have several months to think about it and to improve on the current version. I'm not seeing any questions. Right when I say no questions, we have questions. It's like the magic wand. Let me see. I believe the first hand was from Rep. Schmick. Go ahead, Representative Schmick.
Thanks. I hope that the financial viability of hospitals in the system are taken into account as we want to go down this path, because I think there's risks with implementation.
Thank you. Certainly appreciate that. As we evaluate the rollout of reference-based pricing in PEB and SEB, we can begin to evaluate some of those potential impacts. And there are ways that we can address those impacts through adjustments to our reference pricing. But point well taken. Some exchanges we've had offline have described in Oregon and in Washington declining operating margins for hospitals. Those are averages, and there are several things that are baked into operating margins, but certainly important to consider hospital viability as we consider rolling these out and rolling them out beyond PEB-SEB into potentially the rest of the commercial market. Thank you for that. And Mohammed.
Thank you. Yeah, mine is a cool question. I don't know how are there vacancies in the commission, or should we recruit more? Well, I just want us to move the work forward a lot easier. But this might not be HCA's thing.
Yeah, I can take a first go at that, and would love input from others as well. Noted for the urgency of this work. Healthcare costs continue to go up, access continues to go down, and these are the solutions to some degree that we need to address those problems. We've had some conversations as staff about how to speed up some of this work, and that might look a little bit more like leaning more on work groups. This work group for provider reimbursement has been fantastically productive and really has done some heavy lifting as we sort of get certain other things set, the OIC proviso being one of those, some certainty around primary care directions. I think that we'll have more bandwidth, especially as we have discussed, spinning up work groups from the commission side of things to work on several proposals at once. So, maybe someone's working on a finance proposal while others work on a different design element. but also, you know, certainly the list of ideas that we've come up with is, I'm sure, not exhaustive. So would love to entertain any other suggestions. And Marion, not sure if you have anything to add to that one.
I think, Mohammed, you asked specifically about vacancies, current vacancies on the commission. Did I hear that right?
Yeah, yeah. So
Okay. Yeah.
prudent.
I believe there are 3 vacancies at the moment. And we've been working with the governor. Two of the vacancies are governor appointed positions. And we have been working with the governor's office to raise the issue and try to get these appointments made. But those reside with the governor's office. And then of the other designated seats on the commission, there are 4 designated seats for legislators. And currently 3 of those seats are full. And Ross, you might have to jump in on this. It is the legislative caucus that appoints people. So the seat that we do not have right now, not filled right now, is a Republican member of the Senate. So those are our 3 vacant seats.
No, that's
Thank you.
accurate. I don't have my list right in front of me, but I believe that's accurate.
I will say that we don't have any more questions one more time to see if we get more questions.
Your magic powers.
I think that's that ends it. I will turn it back over to Mary and Chair Lowe.
I'll just turn it right back over to Vicky.
All right, well, I am in my car, so that was our last item of business for the day. And so our next meeting is September 3rd from 2 to 5 p.m. There'll be an FTAC meeting in between, right? The June.
That's correct.
Yes. And yeah, and so the timing's a little off. So hopefully that doesn't disturb schedules too much. But thank you everybody for all your great input today. Really good conversations. Got a lot of things for FTAC to continue to work on. We've got the proposal going forward for the proviso. So thank you everybody for your participation. Thank you to the public for the comments. And of course to our great staff for all their work putting together a wonderful meeting. Hope everybody has a great day. The recording of this meeting will be on the commission's website. That's part of the Healthcare Authority in the very near future. Anything else, Mary?
Oh, no, that's it. Just thanks to everybody.
Yeah. Have a great evening.
All right.
Thank you.
Thanks all.
Thank you.